Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In my previous part 1 video, I talked about etiology, pathophysiology, clinical features and investigations of left-sided heart failure. I've put the link in the description if you'd like to have a look. In this part 2 video, I'd like to discuss the management. As I mentioned in my previous video, acute heart failure is characterized by congestion and low cardiac output. Therefore, the general idea of acute heart failure treatment is to relieve the congestion and myocardial wall stress by lowering the preload or afterload of the heart and by improving the cardiac inotropy. Loop diuretics and hemofiltration are options to reduce the preload, and vasodilators can be used to decrease the afterload. Inotropic agents are useful to enhance cardiac contractility. I've made a video about vasoactive agents, so I've put the link in the description in case you're interested. If there's no response to drugs, we can consider mechanical circulatory support, which I will discuss in a minute. As symptom relief, we should help the patient sit up, and also IV morphine can be used to alleviate anxiety and work of breathing of the patient, thereby lowering the oxygen demand and myocardial workload. To commence the appropriate treatment option, first of all, we need to assess the hemodynamic status and peripheral perfusion of the patient. From our intensivist's point of view, most of the patients with acute left-sided heart failure have features of fluid overload or pulmonary edema. If the peripheral perfusion of the patient is adequate, we should start with loop diuretics like furosemide and monitor the response to the treatment. We can add vasodilators, for example nitrate, if the patient is hypertensive. Renal replacement therapy for ultrafiltration is helpful if the loop diuretic is not working and the renal failure is present at the same time. In cardiogenic shock, the patients are congested and also poorly perfused in peripheries. If the systolic blood pressure is below 90, inotropes, for example dobutamine, mirinone, or levosimendan, together with vasopressors such as noradrenaline, are the first-line treatment option. We can consider trial of loop diuretics when the perfusion is corrected. Vasodilators like nitrate should be cautiously used under close monitoring if the systolic blood pressure becomes more than 90. In refractory cases, discussion with specialist cardiac centers is required to think about mechanical circulatory support. If the patient with acute heart failure has no features of fluid overload and peripheral perfusion is decent, they are clinically stable to be treated medically. If the perfusion is poor, we can give fluid challenge under close monitoring, and if needed, inotropic agents should be started. In patients with acute severe heart failure, ventilatory support is likely to be required as respiratory failure due to impaired gas exchange secondary to pulmonary edema is a frequent feature of acute heart failure. Bear in mind that hyperoxia has been shown to have negative outcomes in patients with acute coronary syndrome. Hence, we should aim for SpO2 target just above 90%. Continuous positive airway pressure is quite beneficial in terms of increased alveolar recruitment, reduced work of breathing, and reduced pulmonary shunting as well as extravascular lung water, so it is widely used on cardiac wards. If the patient is not coping well with CPAP and complicated by airway compromise or reduced GCS, the next step would be intubation and mechanical ventilation with intensive care support. Patients with acute heart failure are so vulnerable to cardiovascular collapse during induction of anesthesia prior to intubation due to negative inotropic and vasodilatory effects of sedatives. Moreover, due to significant increase in intrathoracic pressures secondary to mechanical ventilation, venous return and filling to right heart is reduced, and also due to increased alveolar pressure, pulmonary arterial pressure is elevated, resulting in raised right ventricular afterload. The hemodynamic effects of initiating positive pressure ventilation in acute heart failure could be unpredictable. Therefore, well-experienced ICU team and appropriate resuscitation drugs should be readily available. In fact, not every effect of mechanical ventilation is detrimental towards acute heart failure patients. Extrathoracic pressure is relatively lowered to raise intrathoracic pressure, creating the pressure gradient, so left ventricular afterload and ventricular transmural pressure are reduced, and consequently myocardial supply-demand ratio is improved. After general principles of management and supportive care of acute heart failure, I would like to talk a little bit about mechanical circulatory support, which is more specific to cardiac specialty. It requires specialist review before decision making. Short-term mechanical circulatory support is indicated in patients with acute heart failure or cardiogenic shock who are not responding to medical therapy or who are expected to be potentially harmed by medical therapy. Patients should be evaluated before the decision making to commence mechanical circulatory support by a multidisciplinary team with expertise to select, implant, and manage the mechanical circulatory devices. The factors such as patient's clinical situation, potential hemodynamic impact of the devices, technical aspect of the devices, for instance the ease of insertion, the ultimate goals of circulatory support that we would like to achieve, device availability, and multidisciplinary team familiarity will influence the choice of the device in specialist cardiac centers. Advanced age, significant comorbidity, and established organ failure are considered to be contraindications to mechanical circulatory support. Generally, patients who are not appropriate for anticoagulation, who are having severe peripheral vascular disease, mitral stenosis, aortic regurgitation, and metallic aortic valve replacement are also contraindicated for mechanical circulatory support. Common complications include infection, bleeding, hemolysis, embolic phenomenon, for example stroke, and limb ischemia. There are four main strategies to use mechanical circulatory support. For hemodynamic stabilization of the patients while assessing the reversibility of organ failure and the suitability for long-term mechanical circulatory support or heart transplant. For hemodynamic stabilization of the patients who are appropriate for long-term mechanical circulatory support. For hemodynamic stabilization and maintenance of organ perfusion in cardiac transplant candidates until a suitable donor organ becomes available. And for hemodynamic stabilization of the patients with potentially reversible myocardial dysfunction until cardiac function recovers sufficiently to wean from mechanical circulatory support. What do I mean by hemodynamic stabilization? The patient is hemodynamically stabilized when an organ perfusion is maintained by decent stroke volume and cardiac output, when cardiac perfusion and coronary blood flow are improved, and when ventricular and diastolic volume and wall stress, myocardial workload, and myocardial oxygen consumption are reduced. To achieve all these goals, basically, mechanical circulatory devices can provide support to the left, right, or both ventricles simultaneously. When a gas exchange device is added to the circuit, respiratory support can be provided in combination with circulatory support in patients with coexisting cardiorespiratory failure. Intra-aortic balloon pump, impeller, tandem heart, and veno-arterial extracorporeal membrane oxygenation are commonly used devices for mechanical circulatory support in patients with acute severe heart failure on the intensive care unit. Here, I will briefly talk about each of the devices. Intra-aortic balloon pump is a pneumatic volume displacement device which can be inserted percutaneously, usually via the femoral artery, into the descending aorta. During diastole, the catheter-mounted balloon inflates to enhance native stroke volume by pushing blood volume towards organs, including coronary circulation. During systole, the balloon deflates to reduce the left ventricular afterload, therefore increasing native stroke volume. When using intra-aortic balloon pump, we need to bear in mind that the extent of the hemodynamic support is directly related to native stroke volume. Hence, it will become less effective when left ventricular function is getting more severely impaired. Furthermore, in patients with arrhythmias, the timing of balloon inflation and deflation could be unpredictable, and also excessive tachycardia can lead to the reduction of ventricular filling during the diastole, affecting the cardiac output in a negative way. In most cardiac centers, intra-aortic balloon pump is probably the first line of support because of its familiarity and relatively easy technique for insertion. If the intra-aortic balloon pump is not adequate, or if the patient continues to deteriorate, impeller can be considered as the next step for a higher level of circulatory support. It can be placed percutaneously or surgically via the femoral artery across the aortic valve. It is helpful to displace blood directly from the left ventricle into the ascending aorta for organ perfusion, including coronary arteries. Since impeller tends to support left ventricle only, arrhythmias are poorly tolerated, and adequate right ventricular function is essential to maintain left ventricular preload. In addition to the general complications which I mentioned before, device-specific complications such as aortic valve injury, left ventricular puncture, cardiac tamponade, and ventricular arrhythmias can also occur. If the hemodynamic status of the patient keeps deteriorating, a higher flow device like tandem hub will be required. Tandem hub is a centrifugal support device which drains oxygenated blood from the left atrium by a percutaneously inserted femoral venous cannula which passes into the left atrium via transseptal puncture and then returns the blood via a paracorporeal circuit to the arterial circulation by femoral arterial cannula. Like impeller, the right-sided circulation is unsupported, therefore adequate right ventricular function is necessary, and inotropic agents may be required to maintain left atrial filling and preload. The major limitation here is the need of transseptal puncture, which means that specialist expertise is required, as the septal puncture could be associated with risk of cardiac tamponade. Also, left atrial cannula could be dislodged into the right atrium during the support, which could lead to severe systemic desaturation. Another well-known device for mechanical circulatory support is veno-arterial extracorporeal membrane oxygenation, which is the most appropriate device for patients with biventricular failure, refractory arrhythmia, or impaired oxygenation. It is a centrifugal support device which drains deoxygenated blood from the right atrium via a long femoral venous cannula and returns it via an extracorporeal circuit and oxygenator to the arterial system via a femoral or less commonly axillary arterial cannula. VA ECMO can also be deployed centrally via sternotomy following cardiac surgery. Since venous blood is displaced into the arterial circulation, a gas exchange device is required in the circuit for blood oxygenation. VA ECMO has the ability to support both ventricles and oxygenate blood via the gas exchanger in the circuit. Therefore, it is the mode of choice in most of the patients with acute severe cardiorespiratory failure. The ICU nursing staff and clinical perfusionists who are specifically trained for ECMO are vital to look after such patients. Because the blood is returned to the arterial circulation via retrograde aortic flow, the downside of VA ECMO is that it causes the increase in left ventricular afterload and consequently increase in left ventricular wall stress and myocardial oxygen demand. Vasodilators, inotropes, intra-aortic balloon pump, or impeller device can be added to counter these harmful effects and to maintain left ventricular ejection. The surgically implanted ventricular assist device is a centrifugal support device with a similar principle to VA ECMO, supporting the left ventricle, right ventricle, or both. The key difference is that the inflow and outflow cannulas are directly placed in the chambers of the heart and great vessels, so the patient can mobilize freely, because the femoral vessels are not used. The blood flow is generated through an extracorporeal circuit. To support the left ventricle, the oxygenated blood is drained directly from left atrium or left ventricle and then returned to the aorta. Likewise, if right ventricular support is needed, right atrial or ventricular blood is drained and returned to the pulmonary artery. If the patient is not clinically stable and fit enough for the surgery, however, the device implantation process could be quite challenging due to logistic issues. The ventricular assisted device can be used for long-term, up to months if required. Therefore, it is widely used in transplant centers as a bridge to transplant if the patient is stable enough to continue mobilizing and maintain organ perfusion. For end-stage heart failure, cardiac transplantation is the gold standard therapy. It is a very broad specialized topic, so I will not discuss in this video. Implantable left ventricular assist device is an alternative to heart transplantation and allows patients with persisting advanced heart failure to be discharged from hospital. That's it for me in this video. Hope you learned something new. If you did, please share with your friends and colleagues. I'll see you in the next video. Take care.